And fun fact is that I have a species of ant named after me.
If we have time, we're going to touch on that one later. Sam.
Hey guys, my name is Sam. I'm from Kansas City. I went to the University of Kansas School of Medicine. I'm a third year here now. I'll be one of our chiefs next year with Cassandra, and then going into pulmonary and critical care.
Awesome. And Cassandra.
So my name's Cassandra. I'm one of the third years, like Sam mentioned. After chief year, which I'm very excited about, we'll be doing Chemonc, unless the nurses down here manage to convince me to do palm, which they're trying. Otherwise, in terms of things that I like to do, just hanging out, getting outside. Here in Colorado, I'm from Rhode Island originally, so mountains were a new thing 3 years ago.
Great. And like I said, my name is Danny. I'm one of the current chiefs, and let's get started. So today's case is going to be a cold case. It's going to be, I think, a really excellent combination of diagnosis with actually a fair amount of management. And hopefully everyone will take away some high yield tips for some ICU problems. So as I said, a huge welcome to our applicants. You guys are coming from all over, but we're so happy to have you here. During this conference, please do not feel like you have to participate. You guys should just sit back, enjoy this, and sort of see how amazing our residents are and how incredible they are at their jobs. But if you certainly want to participate, feel free to chime in the chat, put thoughts, ideas, questions. I will try to get to some of those as we're talking, but I also may miss them. So where are you guys coming from? You guys are coming from all over. I was actually kind of stunned last night when I was putting this map together, just how many different medical schools are represented at the interview day today. And it's incredible. Our residency is pretty diverse and from all over the country and even all over the world. And we certainly hope that you guys will highly consider us when it comes time to make your rank list. So this picture is not from today, as the residents will attest. This is about 2 weeks ago, but this is the view from the 10th floor MICU call room, looking back out over the city of Denver. So this is the city, the skyline in the distance. Denver Health is about right here, and the VA is behind us in this image. And then Sam, I think, is somewhere over here right now. So just to, we always say that Denver has the most sunshine. Just so you guys believe that, here's a picture from 1898 that was also sunny and had the similar mountains, and this was taken from downtown. Probably actually pretty close to where Denver Health is today. And we will come back to this image in a little bit. So what is our teaching conference structure? So, prior to the pandemic, we did everything in person, kind of similar to what you guys have probably done at your medical schools. But since the pandemic started, we have moved everything to virtual. So we have a daily virtual conference that we broadcast out to all of our sites, which is what you guys are watching today. And then at some of our sites, and prior to about a month ago, we were still doing some in-person teaching safely. So groups of less than 5 or less than 10. And it was really still a pretty nice addition to our daily virtual conference. We also post all of our conferences to our YouTube channel each day. This is mostly for residents who are on nights who may not get a chance to watch, or anyone who wants to go back and refer to a prior conference. And then, we use our conferences at the end of the month to play some like trivia games and stuff like that, just to hammer home some high yield facts. So with that, let us get started. And so we are going to do the conference today on my iPad. So we're going to use a digital whiteboard to try to kind of mimic the feel of a conference as best we can. And so with that, Cassandra, go ahead and get us started.
Sure. So this is a patient that I admitted. It's a 75-year-old female. She's originally from Corriba, Morocco, who was brought in for worsening shortness of breath by her friend.
Excellent. And sorry, I'm just pulling up the app here. Okay. And Cassandra, take us through all of the sort of initial history.
Sure. So she had this shortness of breath for a couple of days, 1 or 2, prior to admission. She's had a dry cough. Overall, just not really feeling that well. So her friend brought her in. She doesn't speak English. She speaks this specific Moroccan Arabic dialect. So her friend was our translator, because there's actually no language line translator who speaks her language. She was able to tell us that she had a heart issue, but wasn't able to specify past that. She has a history of hypertension, of GERD. She's never had surgery as far as we know. She kindly brought all of her medications, which were written in French, so involved some late night Googling to translate. But she was on a European dosing of aspirin at 75 a day, bisoprolol 2.5 daily, Apoorva, which is an irbesartan and amlodipine combo pill, and then famotidine twice daily. for her allergies. None that she was familiar with or aware of in terms of medication reactions. And then for her social history, so as we've talked about, she actually moved here with her son, but he abandoned her, and she sort of found a community in the mosque here in Denver/Aurora area. So she's been living with this younger woman and her mother. Never drinker, never smoker, no recreational substance use, and just doesn't eat pork because of religious reasons.
Great, excellent initial history. And I applaud you on taking this with a family interpreter. That's a very impressive effort. So with that, let's throw it to our discussants. What do you guys make of this initial aliquot of information?
I guess I can start. So normally when it's like still really broad, I like to think of it in the really big buckets so that I can guide my question asking. So I think I'll think of shortness of breath and cough as two separate issues. So shortness of breath, I often think of the three big chunks of lung, blood, heart as the main, and infection in any of those as like my top thing in my mind when it's associated with cough. And then dry cough alone, I'll actually like expand that out a little bit more and include things like malignancy in an elderly person, autoimmune, and then infectious, as I mentioned, and then GI type symptoms as well. And I'll usually start there to just quickly go over those in my mind and kind of use that to get more information from the patient.
Yeah. And yeah, I think that makes a lot of sense. And I was trying to sort of separate like foreground from background, and who is the, like, thinking about common things being common specifically in the person that we're talking about. So, thinking about someone that's from Morocco, outside the United States, thinking about some of the infections coming from Morocco might be like, this person might have TB that's been reactivated. There's also, a lot of other infectious disease things there that are not here. So I'd wonder about recent travel history.
That's great. Apoorva and August, I think that's fantastic. So like even from that one line or diving into some background stuff, and then Apoorva already thinking and August already thinking in these big buckets about what they're going to do for their next workup. Sam, anything else you want to add or any additional thoughts?
No, I think that's great. I guess one additional question is, how long has she been in the United States? How long ago did she move here from Morocco?
She's been here for a couple of years.
Okay.
Mm-hmm.
Yeah, the only other thing I'll add is she has a couple of reasons to jump out for like chronic cough and shortness of breath, with like GERD, and for heart issue on a beta blocker and an R, like does she have heart failure? It's a little unclear, but it seems like mostly her symptoms are acute.
Great. And then Cassandra, a little bit of additional history. Can you give our discussants sort of when this occurred? So when was this woman presenting to the hospital?
2 weeks ago. And she came in the evening. I would say it was probably 3 a.m. when I was admitting her.
And anything else you guys want to include sort of in your differential, knowing like when this is happening? You guys have already done a fantastic job.
I see some comments in the chat about bisoprolol being a weird medication for her to be on. Her medications were all in French, so I don't think that she gets them from the United States. I think that they're probably from some sort of pharmacy back in Morocco or not the US.
But wait, when thinking about the seasonality of her presentation, I sort of divide the year into mosquito season, depending on where you are, and flu season. So I think that she could have a number of viral etiologies for her cough. Cassandra, you said you were working on the COVID service, is that right?
I am right now. Yep.
Were you working there when this person came in?
I happened to be, yes.
August, nice job. So that is a A+ test taking skill. If you have the seasonality, I think thinking about mosquitoes and viral is actually perfect, like in a non-pandemic year. But once you have that seasonality, like really narrowing in and seeing if that helps, what you guys have already said. And I think that's fantastic. I think you guys did a really awesome job of starting this whole case out. So Cassandra, let's go ahead and keep moving forward and tell us a little bit about this person's initial presenting vitals.
Sure. So I saw her up here in the COVID ICU. Her temperature was 38.7 Celsius. Her heart rate was about 79. Blood pressure was 120s over 88. Her respiratory rate was high, is about 28. And by the time that I saw her, she was on heated high flow nasal cannula. at 90% and 60 liters, saturating at about 93%.
So Apoorva and August, you guys are about a third of the way into your intern year. And I think the important part about intern year is that sick, not sick differential. And what are you guys thinking in terms of sick, not sick for this person?
Sounds reasonably sick to me. Heated high flow being the differentiator there.
Great. I think that's perfect. And if you guys are going to put your nickel down right now on a diagnosis for this person, what would you pick?
Given the base rate of COVID in the greater Denver area in recent days, then I would think seriously about a COVID diagnosis, regardless of test positivity or negativity. If it was negative, I would want to check it again.
Awesome. Cassandra, tell us about this person's COVID test.
So they sent it from the ER and it was positive.
Awesome. So I think everyone right now in their head is probably thinking, did Danny and Cassandra really just present a COVID person during a recruitment noon conference? And the answer is yes, but the case gets better. So let's go ahead and move it over here. And I'm going to pull up the chest x-ray. All right. So I'll give our discussants about 10 or 15 seconds to read this, and then I'm going to have Apoorva give us kind of her focused read. Awesome. And Mark is saying COVID in the setting of MR. I think that's great. So Mark is already thinking ahead, like, could this be COVID plus something else? And with that heart history, maybe trying to tie in a cardiac issue. Love that. And then Dr.
Yeah, I totally agree.
Dr. Heppy also in the chat, he's one of our APDs, just telling us not to forget COVID, like August said with the base rate.
Yeah, I totally agree with what Mark said. There's always Hickham's dictum, which is that any patient can have as many problems as they want, basically. And so I definitely agree that we can't just like stop at the diagnosis of COVID. So looking at this chest x-ray, kind of overall read, the airway does look midline. Looking at all of the lung fields and the diaphragms, there's pretty much obscuration of the diaphragms on both sides by these patchy infiltrates bilaterally. There's also the cardiac silhouette sign a little bit down in the left lower base, indicating that there's a patchy opacity in the left lower lung. And then I'm trying to see if there's any additional lines. I think they're just all EKG leads, but my computer is not great. So that's what my initial sort of read is. I'd say there's also a little bit of kind of reticular opacities in the left upper lobe as well.
Great. Apoorva, that was an awesome read. Sam or August, anything to add?
I would just say that maybe the vasculature maybe looks a little engorged, or maybe you could, I don't know if you can call cephalization of the pulmonary vasculature, but they look a little more prominent than maybe I'm used to, but I think the quality of the film makes it difficult to interpret. And then we did learn classically that with terrible MR, you can have a unilateral opacity in the right upper lobe. I'm not sure this is classic for that, but I do see maybe a slightly more radiopaque opacity kind of just right up there to the upper right of the heart.
Yeah, I think that's great. So Evan brought up in the comments that we talked about this yesterday during our kind of Kahoot, but there's this mnemonic that Dr. Connors uses called Aztecs, which is essentially aspiration. S is silicosis, T is TB, E is eosinophilic diseases, C is CF, and S is sarcoid. And that's your differential for basically upper lobe predominant disease. And you can include acute MR in that E, so as like an edema. And so Evan's a nice job, August as well, kind of referring back to prior conferences. We've got.
And I do have to just since my name was invoked, I have to clarify before Dr. Albert says, what is Connor saying? The A is aspergillus, and this is predominantly for upper lobe cavitary disease. So it can be bilateral upper lobe disease or upper lobe cavitary disease.
Awesome. And then just because Dr. Connors brought it up, Dr. Albert is one of our professors in the pulmonary and critical care department. He's kind of a international expert in all things pulmonary, and he's also on the call today. And Dr. Albert, do you have any additional thoughts on this chest x-ray?
Oh, you are muted there, Rick.
I would just note that the upper lobe vessels that you see on the left side, left upper lobe, they're pretty sharp and distinct. And so I think this makes left-sided pressure elevations less likely, mitral valve disease, if you will. You could argue that there's upper lobe redistribution, but this is a very lordotic film. And so I'm not sure I'd call that. The other thing I notice is that there's a companion shadow missing on the above the clavicle on the left side. I don't think my pointer works. Somebody should use a pointer, but on the right side, you can see a companion shadow on top of the right clavicle, that line right there, right, a little further out, right there. And you don't see that on the other side. It may be just rotation. It may be because it's a lordotic film. But if you see it on one side and you don't see it on the other, you have to worry about something in the supraclavicular fossa that's silhouetting out that clavicle. So I'm sure the physical exam carefully evaluated the supraclavicular fossae, but just in case it didn't, go back and check that. The film is not shot well enough to look at the other companion shadows, the sternocleidomastoid shadows. I wouldn't put this in a predominantly upper lobe group of differential because there's clearly consolidation in the left lower lobe and the right lower lobe. And I think it sure looks like the right hemidiaphragm's elevated, but it's not. That's the rib shadow that we're seeing over there. So I don't see anything else. There might be a hiatus hernia, but I don't think so.
Great. All right, so August, Apoorva, and Sam, you've got this chest x-ray read. You guys have called bilateral infiltrates. What diagnosis do you want to make right now?
COVID.
COVID. And then can we be any more specific than what than just COVID for our discussants? What
Pretty bad COVID.
Pretty bad COVID. I like it.
Acute bilateral infiltrates with hypoxemia concerning for ARDS.
I like it. So Sam has put her nickel down and said this is ARDS, which I think is perfect. So Sam said acute bilateral infiltrates. It's a pulmonary process. She's kind of listing off those Berlin criteria. And we are now officially into this person's like ARDS timeline. So she gets admitted with COVID ARDS to our hospital and Cassandra starts taking care of her. So Cassandra, go ahead and give us sort of the next updates in this person's case.
Sure. So she's admitted. Do you want a physical exam as well?
Yeah, that'd be great.
So I did not palpate her supraclavicular fossa that well at 3 o'clock in the morning, I will admit. Overall, she looks pretty uncomfortable. She had her hair wrapped up in a scarf. She has a black vertical tattoo on her chin and one between her eyebrows on her forehead. She was tachypnic but had no accessory muscle use in terms of her respiratory status. Just very coarse breath sounds bilaterally, no wheezing, no crackles. In terms of her cardiac exam, she had a very loud 4 out of 6 systolic murmur, best heard in her left upper sternal border, but radiating throughout her chest wall. She had dry mucous membranes and had no lower extremity edema or general volume overload either.
Great, really good exam. We'll talk more about this exam in just a second. Cassandra, go ahead and sort of start us on this timeline. So what happened after she got admitted?
So she was admitted. Overnight, I honestly did not do much for her aside from the general COVID treatment. So she got some dexamethasone and remdesivir, sent some screening labs for HIV and Hep C, and she did well overnight on her heated high flow nasal cannula. We were actually able to wean her down to about, I believe, 50 liters that night. The next day, she was still stable. So we transferred her to our step-down team. That day, she was stable on her heated high flow, still no significant changes. 2 days later, she was persistently hypoxic despite maximal heated high flow therapy. So she was sent back to us in the COVID ICU for intubation given her persistent hypoxia.
Great. So let's stop right there. So this person is going to get intubated right now. And as the sort of intern at the bedside, you guys are going to be responsible for putting all those initial orders. So the chest x-ray, the vent orders, and everything like that, so our RTs can do their job. And so what is for August and Apoorva, what is that first thing that we need to worry about and the first thing that we need to set on the ventilator after we intubate someone?
You just think about the fraction of inspired oxygen, the FiO2.
Okay, so we'll set the FiO2, great, that'll be one of our variables. Anything else that we want to set first? PEEP and tidal volume being the other things that we fiddle with on a vent at that stage. Perfect. Yeah. So you're correct. So we want to basically put this person on low tidal volume ventilation. And so like a really quick teaching point here. So low tidal volume ventilation, this comes from our trial, the ARMA trial, which came out in 2000. So sort of the first there are a bunch of landmark trials, but a landmark trial in 2000 that defines what we do. And so what did ARMA look at? So ARMA basically compared 6 cc's per kilogram tidal volume and a plateau pressure of less than 30 versus 12 cc's per kilogram and a plateau pressure of less than 50. And so if you guys were betting people, which one of these two options do you think was associated with reduced mortality?
I remember it's the low tidal volumes because we think it causes less barotrauma to the lungs in ARDS.
Yep. Great. So reduced mortality in the 6 cc per kilogram group. And Apoorva, I'm glad you hit on that. So you said reduced barotrauma, which is close. So actually the sort of overriding reason we think here is it's a decrease in volume trauma. So basically the smaller tidal volume causes less volume trauma. If you look at the study, and maybe Dr. Albert or Dr. Connors can comment on this, the barotrauma, sort of defined as pneumothorax, was the same in both groups, but probably still some contribution. So this definitely reduced mortality. So it was 31 versus 39%. And so as the intern, when you are having an intubated patient, making sure right away that they are on 6 cc's per kilogram after they are intubated is one of those things that helps people survive longer in ARDS. So Cassandra, this person gets intubated, they get put on low tidal volume or lung protective ventilation. What happens next?
So that day, just to give you an idea of her vent settings at that time, she was on a PEEP of 10 and FiO2 of 60% after intubation. She settled out for the rest of the day. We got some additional diagnostic studies, which I'm happy to talk about if you'd like. But that day was pretty stable for her once she was intubated.
Okay.
Cassandra, I just had a follow-up question. Was she already antibioticed at this point from day one, or did she get antibiotics when she goes on the ventilator? How did that work out for her?
Great question. So she had been afebrile throughout her stay. Her white blood cell count was normal. Her procal was 0.04 in admission. So she was not antibioticed initially, thought to be mostly a viral pneumonia in the setting of her COVID, no bacterial pneumonia in terms of her clinical presentation.
Great, thank you.
Great. Mm-hmm. And then Cassandra, August is asking about whether an echo was ever done.
It was actually done the day that she was intubated. The pertinent finding there was finding of severe aortic stenosis by all 3 criteria. And if you look back at her chest x-ray, you can almost see the calcifications of her annulus with that valve.
Great. So for our discussants, Apoorva, August, and Sam, does severe aortic stenosis sort of change the way you're going to manage this person or change the way you're going to think about this person's care?
It does. Worry about them potentially being very sensitive to afterload and dependent on preload.
Great. And so how is that going to, on sort of a day-to-day basis, how is that going to come into your kind of thought process? How are you going to use that to affect the decisions you make?
So I, especially in someone with a super fluffy chest x-ray, I worry about like cardiogenic pulmonary edema as a result of reduced forward flow, but I would be, I guess, more hesitant to aggressively diurese in someone that I think is more preload dependent.
Awesome. That is actually a great segue into the next thing we do for people who have ARDS. And so if you keep going sort of down this timeline, in 2006, a second trial came out called the FACT trial. And the FACT trial is basically exactly what August was just describing. It was a dry lung is a happy lung. And essentially the big takeaway from the FACT trial is that we should sort of always be aware of our patient's volume status. Because we know that people who have sort of a euvolemic or dry lung spend less time on the ventilator, less time in the ICU, and sort of have higher rates, higher oxygenation. Doesn't affect mortality, but it's something that we should be aware of after the person gets intubated. So I think the fact that August was able to sort of tie these two things together is awesome. All right, Cassandra, in the sake of time,
Sure.
What happens after a couple days of intubation?
So she had increasing ventilator requirements in order to maintain appropriate oxygenation. So she was up to a PEEP of 12 and an FiO2 of 70%. Despite going up on her vent settings, her ABG at that time, I can read it out for you, was 7.4, 40, 59, 25, and that was on the 60% and 12 of PEEP at that time.
Excellent. And so for our discussants, what do you guys want to do at this point?
And I guess to clarify, that gives her a P to F of 98, just to eliminate math.
I think all of our discussants are thankful, as well as I am, to provided that math for us.
Sandra, what was her initial P to F, and was she ever proned?
So this was day 2 of intubation. Her initial P to Fs were fine. They were above 150. It was just that second day of intubation, she sort of progressively became more hypoxic despite increasing ventilator requirements.
So Sam, what do you want to do?
Well, definitely like meets criteria for proning with a P to F less than 150 on at least 5 of PEEP and 60% FiO2. There's always this, I think this is still considered, early proning. She's day 2 of intubation, but there's always this gray area where the farther you get into being intubated at one point, you're still early proning.
Awesome. Yeah, so this is early proning. So Sam's hit on this perfectly. So Sam says she wants to prone this person. And sort of to continue our really brief landmark trial tour of ARDS, Sam, what trial is this?
Proceedvo.
Awesome. So this is the Proceedvo trial. And strangely enough, these all sort of come out in order. This one came out in 2013. And so the Proceedvo trial, just like Sam said, basically said that if you were on an FiO2 of 60% or higher and a PEEP that was greater than or equal to 5, and your P to F was less than 150, they trialed prone times 16 hours versus supine. And again, if you guys were betting people, what do you think the mortality outcome here is going to be?
Decreased mortality in early proning.
Awesome. And August, you're exactly correct. It had to be basically 24 hours to see if people had resolved with just sort of more supportive care. That's exactly correct. Yeah. So this is decreased mortality. And so we look back at the ARMA trial, that was like an 8% mortality difference. This drop was about 17%. So even more so than the ARMA trial. And so a really staggering improvement in mortality. And so I think we talk a lot about ARDS and proning, but I think one of the things that's always instructive is to just review really quickly why it works. And I'll say I'm slightly nervous to talk about why this works because we have truly an expert on the call with Dr. Albert, who has spent like a not insignificant portion of his life talking about this. And so Dr. Albert, please jump in at any point when I say something incorrect. So this is a CT scan slice from a patient who has ARDS. This is not our patient. We'll get to their CT scan here later, but this is a patient with ARDS, and you can tell that there's bilateral sort of dependent infiltrates on both sides. And so sort of the classic teaching is in this position, blood flow is gravity dependent. And so you're basically perfusing regions of the lung that are poorly ventilated. And you have this kind of baby lung up here. So you have a healthy portion of the lung, which is receiving the bulk of the ventilation. And so in this position, when you are supine, it leads to sort of poor VQ matching and hypoxia. So what happens then if we take this person and we prone them? So we flip them over on their belly. And sort of the classical teaching is that basically 3 things happen. You get redistribution of the dependent edema. It sort of becomes more homogeneous on both sides. You now get better blood flow through regions of the lung that are better ventilated. And then the weight of the heart and chest wall fall forward and off the lungs. And so these sort of 3 things all come together. And so in the prone position, you get better VQ matching and you improve hypoxia. Now,
So,
Dr. Albert, Dr.
Yeah,
Albert,
I've got to jump in here.
I know he's going to say too, and I'm happy. So, Dr. Albert, tell me why this is
Alright.
actually not really.
Yeah, there's several reasons why. The first reason is that the perfusion, while affected by gravity, is not gravitational dependent in any major way. 7% of the perfusion redistribution that occurs when you go from supine to prone is accounted for by gravity. When you are prone, the bulk of your perfusion goes to your dorsal lungs that are in the non-dependent region. The reason perfusion stays there is an anatomic issue, not so much gravity. And it's quite key. It's very important that the perfusion continue to be preferentially distributed to the non-dependent lung in the prone position. Why? Because when you turn prone, all that consolidation that you see in the dependent lung supine, most of it goes away. And the end expiratory lung volume when you are supine, when you're prone, is much more homogeneously distributed, even top to bottom. Whereas opposed when you're supine, the end expiratory lung volume is way lower in the dependent regions and way higher in the non-dependent regions. So it's basically a redistribution of ventilation with no change or very little change in perfusion. Why does that ventilation and lung volume homogeneity change when you go prone? Because the lung fits better in the chest when you're prone than when you're supine. As in part because of the heart. Notice that the heart is sitting on the sternum. Well, you can't tell from that view, but the heart sits on the sternum when you're prone. When you're supine, the heart sits on the left and right lower lobes, and it helps squash it. And the other major factor is the curvature of the diaphragm. Abdominal contents presses on the dorsal caudal lung regions when you're supine as opposed to being prone. That's the primary mechanism by which it works.
Awesome. Thank you, Dr. Albert. I knew that was coming, and because I think it's
very misleading just to take a supine view and turn it over, because all that consolidation in the dorsal caudal lung region, most of it's going to go away when you turn people prone. And in fairness, some will develop in the ventral regions now that they're dependent, although not nearly as much. The pleural pressure gradient, there's a gravitational gradient of pleural pressure from top to bottom. You guys all know this. The average pleural pressure sitting up is -5, but it's about -10 at the top of the lung and close to 0 at the bottom of the lung. There's a gravitational gradient. That gradient persists when you're upright, when you're supine, or when you're in a lateral decubitus position, either one. But when you're prone, that gradient almost goes away because their lung fits into the chest better with less distortion.
excellent. So Cassandra, so what happens after this person gets proned, and sort of walk us through what happened next?
So we left for the day and left this act to our colleague who's covering at night. So everybody got ready in terms of nursing and respiratory therapy staff to prone this patient. We flipped her over, and almost immediately upon being proned, she had high pressure alarms going off on her ventilator. So her peak pressures were high 30s, so 35, 36, even hitting 40s in this moment. She was hypoxic to the 70s, even with us switching her FiO2 over to 100% in that moment. And then also hypotensive, hitting 60s over 40s with her pressures, all in this act of proning.
Excellent. So for August, Apoorva, and Sam, if you guys get this nursing call that this person's now hypoxic and hypotensive when proned, what's going through your mind? Like, what are your next steps, and how do you work through that as you walk to the room?
If I'm remembering this correctly, I think peak pressure is indicative of more so your resistance in the airways. And so I think of things that would be causing problems with that. So the primary thing that jumped to my mind with the hypotension, hypoxia, and then high peak pressures is like a pneumothorax. And so I would probably get some repeat imaging. And I can't remember exactly if I'm remembering peak and plateau pressures correctly, but I think that's what.
Yeah, it's a good point. So pneumothorax will increase both your peak and your plateau, but it's certainly something to consider on there. I love it. So you also mentioned plateau as well, which we can talk about here in just a second. And what else is going through your mind? So we thought pneumothorax, which is great, tie together the hypotension and hypoxia. Anything else?
I guess that there are sort of a couple ways to think about this. I was thinking about, like, in medicine, we are just like observing the phenomena in the natural world. We don't get to control how they present, but we at least get to think about how we think about them. So I feel like the ways that I've been taught to break down hypoxia are either sort of physiologic, where we think about VQ mismatching, versus hypoventilation, or anatomic, where we sort of walk through each organ system that could be contributing to their hypoxia. So yeah, and depending on how you like to do it, in this case, I think I would probably try to think more anatomically, because everything is VQ mismatch. And so I would try to get a set of vital signs to see if there's any suspicion that this person is is hypoventilating, to make sure that they have a good respiratory drive and not having a central process. We didn't accidentally like trip and fall on the fentanyl syringe at the same time that we were proning them. I would also get a chest X-ray, ABG, EKG, to rule out other sort of possibilities of badness there. I think that, and then I would also obviously like want the O2 sat from the vitals. And then in thinking about these high pressures, I would want to perform an inspiratory hold maneuver to try to see if the reason that the gas is not getting to the lungs is because there's a problem with the tubing or the airways themselves, whether that be like a mucus plug or or like an obstruction in the line. Like maybe did we kink the ET tube in the moment of proning, versus is this a problem with the lung parenchyma itself, where we're seeing like a sudden decrease in compliance.
Awesome. August, that was great. I really like the way you thought through that. So sort of anatomic, but then also like going straight to the ventilator. Sam, anything you would add?
I think this is all excellent. I agree with what's been said of like all those three things happening concurrently with proning. I can't immediately make sense of. And so I think it's good to think of those three problems separately. We've talked about sort of the differential for hypoxia, and it's like all of a sudden now she's displaying shunt physiology, and that we've turned her FiO2 up to 100% and she's not correcting. So trying to think about what about proning could have caused like sudden shunt physiology in her. And same with thinking about hypotension, I guess is the one thing we haven't really explored of those three. My differential for hypotension is basically the same framework I have for shock, like we're seeing septic shock, cardiogenic, hypovolemic, hemorrhagic, or then like iatrogenic and sort of some other more rare etiologies. And I feel like there's something here maybe with her severe aortic stenosis and prone positioning that can tie these together that I can't totally make sense of yet.
Completely agree. So in the sake of time, you guys have hit on everything that I think Adam Starr, who was the resident overnight, was thinking when he walked in the room. Like, is this cardiac? Can I tie that to the prone positioning? Is this pulmonary? Gets a chest X-ray and it looks essentially unchanged. And then he gets an ABG and an ABG as well. And just, we'll show this quickly here, but then we'll move on to sort of the next diagnostic dilemma. But so this is this person's basically vent settings and ABG, 2 ABGs during the time course of this event. And so this is how, for the applicants, this is how it looks in EPIC when the RTs sort of report their vent changes. And so they go from 70% FiO2 to 100%. Their PEEP stays stable at 12, goes to 12. Their static pressure, which is what static pressure is what August was referring to with his plateau pressure and the inspiratory hold, goes from 20 to 24. And so the ABGs down here sort of just show this person sort of remains extremely hypoxic even as the vent increases. And so Cassandra, what did you guys end up doing for this person and sort of the next workup step?
Sure. So just given how unstable she was in the moment, staff was very concerned that she could possibly code during this event. So flipped her immediately back over supine. Adam did a great job overnight and started broad spectrum antibiotics. He was concerned about this hypotension possibly being a source of sepsis. On exam, there was some concern for tracheal deviation, so he ordered a stat chest x-ray. He was also concerned about this new hypotension and hypoxia possibly being caused by a PE, so he started a heparin drip empirically. He gave her a little bit of diuresis in case her hypoxia was due to volume overload. And then because she didn't tolerate that proning event, he also put her on paralytics in hopes of increasing her PDEF.
Great. Awesome. And so I think Adam did a really excellent job. So right, real world, it's nice to think about the diagnosis, but when someone is this sick, sometimes you just have to do all the things for them in sort of an expeditious manner. So antibiotics, chest x-ray, heparin drip while CTPE is pending, diuresis in case we can tie this to the aortic stenosis, and then paralytics. And we won't touch on this more, but the paralytics came from something called the Rose trial. We used to just sort of paralyze everyone with severe ARDS, but in 2019, we had this new study which showed that we now typically only do it for sort of vent dyssynchrony and refractory hypoxia, or a combination of the two. And we were one of the centers that participated in that trial. All right, Cassandra, so the next big thing that happens in this workup, which really sort of almost ends the case, is a CTPE is performed. So
can I actually jump in before we get to that?
Yeah.
So the CTPE didn't happen for some time, but we did get her chest x-ray back immediately once she was proned. And it was actually discovered that her endotracheal tube was pretty much right at her carina. So it had slipped from its positioning when she was proned. And so what we thought happened was possibly that when she was proned, there was significant pressure sort of driving that ET tube directly into her carina, which would then increase her intrathoracic pressure, causing her to reduce preload with her aortic stenosis, dropping her blood pressure, and then causing the subsequent hypoxia and hemodynamic instability. It was retracted by about 4 centimeters, and she did fine with her oxygenation after that.
Awesome. That's great.
I think it's important. I actually wrote that into Augie as an option because her problem occurred while she was turning prone, being turned prone. Movement of the endotracheal tube down the right main stem or close to that is an obvious possible explanation for everything that happened. The point I want to make is that shouldn't have happened. When people get turned prone, one person, usually a respiratory therapist, but it could even be a housekeeper, needs to hold the endotracheal tube in place and focus completely on that, because movement of the endotracheal tube when you're turning is the only thing that could happen that's disastrous when you're turning people prone. And that represented an error, in my opinion, with respect to the mechanics of turning somebody prone. It's just not acceptable to have the airway move. Somebody had to have that as a primary responsibility.
I think that's a wonderful teaching point from Dr. Albert. Just another thing to add to your sort of diagnostic schema when you're walking into the room, if someone's decompensated after being prone, is to check the airway and get the chest x-ray to make sure that that endotracheal tube is in the right position. Perfect. Okay. Here's the CTPE that was performed to make the decision about whether the heparin drip could be stopped. And so we're going to crowdsource the read of this. And so I'm going to play it through, and I want you guys to throw into the chat any abnormalities that you see. The abnormalities are quite subtle, which is why we kind of defer to radiology on things like this. But if anyone can correctly point out the 2 major abnormalities, I will be very, very impressed. There's some positive arrow signs there if anyone catches them. All right, I'm going to rewind this here. Play it one more time. So Schweib says there's a large PA. I believe the PA was a little bit large. All right. Dr. Albert or Dr. Connors, do you guys see anything on here?
That went too fast for me.
Let me, so I'll say the kind of the notable cut is right about here. And this is the cut that it's right below the arrows, August. And so what are you guys noticing on this cut? What is this?
I don't know. Broncolith.
Do you want
perhaps?
us, Danny, Dr. Albert and I, or you want the residents?
Up to you. I'm happy if you guys want to chime in. I think this was, I would say from talking to Cassandra, it sounds like this was a radiologist to attending conversation because it was such a subtle finding.
Yeah. So, I mean, you've got bright white there in the subcarinal area. That's your station 7 nodes. You know, there's probably a CT from before this, so it'd be easy to see if that's calcium. That would be the most likely cause all comers, is that's a calcified node at station 7. You know, you guys probably aren't going to show us a chronically calcified node, although she's got lots of risk factors for that being in Morocco. So the other thing that's going to be bright white on a contrasted study is going to be blood. It's going to be contrast that has somehow leaked out into that area in an acute fashion.
Great. So calcified node versus blood. And then the other radiology read is right here. And so what they called that as, sorry, Dr. Albert, go ahead.
Well, it looks like there's an indentation there that would be consistent with an embolus, but you need, or a thrombus, you need to go up and down a little bit to verify that. Her left pulmonary artery is kind of tortuous, so it may be an artifact of that, but it looks like there's a filling defect there.
Awesome. And that is exactly correct. So it's a chronically occluded vessel. And so Cassandra, what was the combination of a calcified node and a chronically occluded vessel? What diagnosis did the radiologist call and tell you guys about?
So the radiologist called pretty frantically, and we spoke. I said, I'm most concerned about a PE in this patient. And she clarified that with this combination of how chronic the occluded vessels looked, that she did not believe it was a PE. And instead, she was worried about fibrosing mediastinitis in this patient.
Awesome. So a diagnosis called fibrosing mediastinitis. And so I have absolutely no framework for working through that. Do any of our discussants have a framework for thinking about fibrosing mediastinitis?
Definitely not.
I do.
And if you do, share it with Dr. Albert and I.
So,
Well, we don't, I mean, this isn't a critical care issue. Fibrosing mediastinitis is seen primarily in patients with histoplasmosis. And you usually see more than what I see here, frankly. I don't see mediastinal fibrosis. Her mediastinum looks clean. I see the calcium and I see the indentation, and I guess I would not have called fibrosing mediastinitis here.
and I think that speaks to how subtle the finding was. And I think it was a fairly long conversation with radiology. And I had also never heard of fibrosing mediastinitis before. Evan's there as an intern who is, I think, smarter than most of us. And so Dr. Albert's correct and Evan's correct. In the US, the most common cause is histo, but then once we sort of go out to the broader world, the most common cause is TB.
TB, yeah.
And so then when we're thinking about sort of like where does fibrosing mediastinitis affect, it's sort of the vessels. So the pulmonary vasculature, like in this case, the esophagus, the SVC, essentially anything in the mediastinum can be compressed by fibrosing mediastinitis.
But usually the pulmonary veins as opposed to the pulmonary arteries.
Interesting. So it's not typically the PA, it's the pulmonary vein.
But because the veins are a lower pressure circuit, so the narrowing affects it much more commonly.
Interesting. And so treatment then, we get into treatment if they have active TB or active histo, you want to treat both of those. But otherwise, it's a huge black box. We don't really know what to do with this condition. It's sort of slowly insidious and progressive. And so Cassandra, fill us in. What happened after you guys got the CT scan back?
So we got that back, and our attending was pretty worried about either histo or TB given her country of origin. So I had sent off an AFB respiratory culture, and here at the university you can also order the MTB PCR in addition to that. So I sent that on the first one as well, and then also ordered her histo, serum antigens and antibodies.
Awesome. And what was the final diagnosis?
So at about 10:30 p.m. at night, maybe like 2 hours after ordering that study, her AFB PCR came back positive. Got many frantic messages from infection control about how she needed to be on airborne, and I clarified like, hey, she actually has COVID as well, so we're good. And so she's a dual diagnosis of TB and COVID.
Awesome. And so me and Cassandra looked into this a couple days ago, and there have only been like less than 100 or so reported cases of sort of dual infection since the pandemic started, most of them coming out of Europe. And so I think this was a really excellent case of, you know, a common thing, and then a secondary infection based on sort of patient risk factors. And so actually, if we zoom back into the very initial part of this thing, when you guys were taking her initial history, you guys, August had that background information and immediately thought, could this be TB? And so I think just a really great example of sort of that clinical diagnosis really early on, and then sort of keeping that in the back of your mind as you go further. Cassandra, any additional thoughts about this case or sort of your experience in the Surge ICU?
Yeah, just for the patient herself. So we do think that she probably had been exposed to TB very early on in her life. And in speaking with her friend she lived with, she confirmed that like all of them had been exposed to TB when they were back in Morocco. And so she's on treatment right now with RIPE therapy. If you can imagine, she was living in close proximity with 2 other people. So the Denver Health Tuberculosis Clinic helped us out with contact tracing. So they called her friend, spoke with the mom, and they're all getting tested and will be treated for free if they are positive, which I suspect they most likely will be. Otherwise, she's doing pretty well. We're actually proning her for the first time today for some low PDFs. In terms of experiences in the Surge ICU overall, it's definitely been a long month, a lot of really sick patients. But the one thing that I've walked away from this month with is just the importance of interdisciplinary care. So as you can imagine, like most hospitals across the country, we have faced issues with you know, not having enough nurses, not having enough CNAs. So as a resident, I think that sometimes we sort of take a step back and we're like, well, I ordered the scan on the computer, so it should just happen. But these last 3 weeks, it's been a lot of learning, like what does it mean for a nurse to actually take a patient down to a CAT scan? How can I help send labs? How can I help with proning? And I've really begun to realize like nurses do so much work that we never even dream of. And just building that good collegial relationship has been so important for not only our own morale, but for taking care of the patients as best as we can.
Awesome, Cassandra. Thank you so much for sharing that, and thank you for preparing for this case. I think it's a really great case where it starts out with sort of a horse, right? But then we sort of weave into eventually it being a zebra, and it sort of kind of threads that line of sort of diagnosis and management. So Cassandra hit on something. So this person was referred to the Denver TB clinic. This is one of our doctors at Denver Health, where our Denver TB, our Metro TB clinic is held. And so obviously, you know, we're going to come back to this picture for just a minute. So this is from 1898. And so we hope that for all the applicants, you guys come to Denver because it's the best training experience in the country. Our PD and our APDs are fantastic. And I think the residents are honestly the best part of this program. But that was not always the reason why people came to Colorado. So people initially came to Colorado because of TB. And so there were sort of some reports that as of like, you know, in the 1920s or so, roughly 1 in 3 people in the state had TB. This is a picture of some TB huts outside Colorado Springs from the early 20th century. These are some more TB huts in Colorado Springs. And then these are the individuals who were staying in the sanatoriums where these huts were. And so Colorado, we're always sunny. There's great air. There's a lot of sunshine. There's, you know, back in the day, they thought there was better nourishment here as well. And so it applies to TB treatment then, and it applies to sort of residency in life now. This is a building, this is the initial National Jewish Hospital in 1920, a place you can rotate for allergy, immunology, and pulmonary. And then this is sort of a picture of heliotherapy for TB when we thought sunlight cured TB in the 1930s. And then finally, you know, this is still a building that exists in National Jewish. This is 1950. And then this is what the National Jewish Hospital looks like now. So thank you to all of our discussants. You guys did fantastic. I'm so happy that you guys could participate today. And to all of our applicants, thank you for watching. Hopefully you enjoyed the conference and you got to see just how good our residents are at what they do on a daily basis and how thoughtful and, you know, just amazing clinicians they are. And yeah, thank you everyone.
I want to say thank you as well to Danny for preparing that case and all the little historical facts around that. That was really fun. That was awesome. And residents, great job. I mean, not surprising that you had that up there very early on. I'm just really impressed. And Cassandra, I loved your message. I thought that was excellent. This is radiology helped make the case all day long. So that's pretty great. Nice job, everybody.